Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer that has been working with CCF, the Carcinoid Cancer Foundation, for 10 years. That is 1 decade of my life and my career, and I couldn't be happier with the work that we have done. And during that time, we have created hundreds of videos. We have done a lot of live videos like the one you're going to watch today. We've done documentary style patient-centric stories. We've done treatment-based videos, event coverage, all sorts of video content, but all with the same mission in mind, and that is to help spread awareness and education about neuroendocrine tumors. So if you are new to the show, if this is your first time here, first of all, I want to say welcome. And I highly encourage you to introduce yourself in the comments to the community. A big part of the show, besides the information that you will get from the expert today, is really the community that we've helped cultivate here. The NET community is a strong one, and the more you lean into that community, the more they will embrace you and protect you and take care of you. It's a very, very strong community, and I already see some of those people who are regulars to the show chiming in and telling us where they are in the world. We'd love to see how far these programs reach. So introduce yourself, say hello, get ready for the next hour where we're going to give you some great information about neuroendocrine tumors. So before we move forward, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Without their support, we wouldn't be able to do Lunch with the Experts. And we also have this disclaimer from them at the top of every program, and that is that the opinions expressed today by our guest presenter, as well as the questions asked by you all, the audience at home, haven't been created or suggested ahead of time by the sponsors of Lunch with the Experts. And CCF doesn't endorse or promote any of these views, opinions, or information that will be provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. All right, a lot of words, but really one central takeaway there, and that is we or our guest today does not know your specific case. So we're going to give you some great advice, some general advice, and some answers to your question. But because we don't know your specific case, take that advice and those answers back to your home team, which does, and make the best plan and path forward for you. Because as I say, if I've learned anything in the past 10 years working with CCF, is that it is that each case of this disease is unique, and therefore each plan and path forward is as well. Okay, folks, today I am excited to welcome back to the show for the second time. We had him on the show about a year ago, Dr. Boris Naraev, and he says that Naraev has arrived. So welcome to the show, Dr. Naraev. Tell us, for those who maybe didn't see you the first time, a little bit about what you do. And I know that you have some news. You just changed positions at a new institution, so we'd love to hear all about that.
Yes, thank you very much for having me for the second time. It was a pleasure, and it is a pleasure now. And you are correct. For the last 7 years or so, I was in Arizona. I was helping to build and eventually lead one of the largest neuroendocrine cancer programs in the Southwest. The program is quite successful with lots of patients being helped. And you are correct. Recently, I moved to Jupiter, Florida, the Anderson Family Cancer Institute here at Jupiter Medical Center, with hopes and plans to fill the need here and build another successful neuroendocrine cancer program.
What's your official, has your position changed there?
Well, this is new cancer center. This is new program. Officially, it's called Gastrointestinal, Neuroendocrine, and Rare Cancers Program, which tells you that neuroendocrine cancers are not that rare anymore.
Indeed.
So, and I'm leading this program.
So you're kind of, is it fair to say you're building this program from the ground up, or?
Yes, essentially. We have all the components. Now we need to put them together and make them work together.
Very exciting, very exciting. And I agree with you. I think it's great that these institutions are popping up more and more, but I agree it's not such a rare cancer anymore. But I'm looking forward to learning more about the components that you're putting in place. That's exciting. So folks, if you have questions for Dr. Naraev, go ahead and start sending them in. For those that are new, Fernando says Florida has gotten a great doctor. I agree, Fernando. And
Thank you.
also Dr. Naraev, I think he likes being in Florida. He told me before we started recording today, which who wouldn't, right? I just got back last week. It's beautiful down there. The weather's great. So yeah, go ahead and start sending in your questions. Here's how the show is going to go. We have 1 hour. We're going to try to get to as many questions as we can, but inevitably we don't because we get hundreds of questions sometimes. So if you don't get your question answered or you have a follow-up question, reach out to CCF. After the show, you can privately message them on Facebook. You can reach them at carcinoid.org. Also, you have the option to watch the replay. As soon as the video is done live, it will be posted on Facebook under the videos tab. And starting next week, we will have it on YouTube as well for those that don't have Facebook. If someone does have Facebook, but they're not here right now, and you know they would benefit from this show, let them know in the comments or share the video to their wall. Let them know the video is going on, because the real value, the replay is going to be great for sure. But the real value is this interactive session and getting across a question that you may have been struggling with. So if we can get them here in the house, we want to. And secondly, if you see a question that you have in the sidebar, just under the comments, there's the option to reply or to like it. And if you like it, or if you hover over that, they give you other emotions you can use. You can love it, care for it, whatever. They all work the same way for me. And that is to effectively upvote that question, right? So again, we have hundreds of questions. We can't get to them all. If I see that 8 people have the same question, I'm going to know, hey, Rain, that's a very important one to get across. Therefore, I will make sure that I ask it. All right. That just helps me do my job a little bit better. So, man, we got a great attendance already today. It must say a lot about our guest. So, Dr. Naraev, I know you were 7 years with out in Phoenix. What were you doing before that? Were you working with NETs before that?
Yes, I was working with neuroendocrine tumors since the beginning of my fellowship at the University of Iowa Hospitals and Clinics under the guidance of late Dr. Odericio and Dr. Habdanarson. So the experience started there. Subsequently, I continued into private practice in New Mexico, where I was seeing patients with neuroendocrine tumors. And we managed to treat some of them with PRRT in Houston, because PRRT, as you know, was not available in those days. Right. So we sent them to Excel Diagnostics. And subsequently, I moved to Phoenix, and you heard the rest of the story. And here I am in Jupiter, Florida.
Well, that is quite a journey for you. And definitely the University of Iowa is one of those major institutions. I definitely want to send love to Dr. Tom Odericio, who we lost earlier this year, and was a friend of mine, a friend of the foundation, and just I would say a titan in the NET community. So we hate that we lost him. What a great soul he was. So how many of what is the percentage of your patients that are neuroendocrine tumor patients currently?
Well, we just started the program, but the latest data that I have from the previous practice, where we became this center of referrals locally, I think 80% of clinic was composed of visits with patients with neuroendocrine tumors of any location. So we definitely hope that we will grow the program again, and we will see mostly patients with neuroendocrine tumors. But hey, we just started here. People are already coming. People are already coming, even from other countries. I was surprised, but it so happened.
Yeah, I'm sure that it will happen fast. So where I was going with that was, I'm always interested in, in what drives you or drove you initially to pursue treating neuroendocrine tumor patients. You said 80% of your practice, so obviously that's a majority by far. What is it that interests you, that challenges you? Is it a challenge? Like, what is it that draws you to that disease specifically, if anything?
Well, right now I'm so many years into it, but when it was just starting many years ago, it was a challenge because if you recall, there was nothing available, not much. Right. I still remember the day when everolimus was officially approved, and it became the big deal because we finally got something new to work with. Mm-hmm. So in those days, it was a challenge. It was considered to be a rare disease with reasonably few treatment options. Not much was available. And there was great hope because PRRT already existed in Europe.
Yes.
So Dr. Odericio was particularly into it. And as you know, one of the first trials was done at the VA hospital in Iowa City in those days. including the imaging related to somatostatin receptor type 2 utilization. So it was exciting then. And once you are in, you are in. And now it is probably, I should say, maybe a little bit less challenging because we have many more treatment options. But it's still exciting because now, before problem was what to do, the problem now is what to do with all those treatment options. Because as you probably heard from people before me on this broadcast, that now sequencing is the problem. It was never the problem because there was not much to sequence. Now we have a lot of things to sequence and lots of research going on, and we're trying to incorporate the data. So it's challenging and exciting.
Yeah, that's such a great point. I'm sure we will come back to that in terms of sequencing. We often do, but we're getting a lot of questions already in from the audience, as we normally do. So let's go ahead and start taking some of those. The first one comes from Nancy, who says, okay, this is an odd one. I was on Sandostatin from 12/20 so December 20th to May 2021, not December 20th, December 2020 to May 2021. I've never had chemotherapy, but a few months ago, my hair became very curly for the first time in my life. Can Sandostatin do that?
Theoretically, yes. It's not a known side effect or consequence, but Sandostatin, it's a somatostatin analog, and somatostatin is a universal switch off, as Dr. Oderisi used to say. So it switches off many functions in the body and off the body. So everything is possible, unless something else changed that could potentially explain that. So we could think about Sandostatin. However, it's not something common. We do see quite frequently when people, you are correct, when people are on chemotherapy or after chemotherapy and they lose hair, frequently hair comes back different texture, different structure, not necessarily different color. No one yet turned to be a redhead, brunette or blonde, but the texture of hair could change after chemotherapy. So with Sandostatin, we don't see it frequently, but again, if nothing else happened, you could think about it.
Got it. Yeah, that's interesting, Nancy. So I will say to everyone listening, this is one of those things that often during the show, if it's not a common symptom, as Dr. Naraev said, it may be something that's experienced by other people. So sometimes the other people in attendance can join, chime in and share their experience, and typically they will. So if anyone else has experienced something like that, let Nancy know. Okay, moving forward, Simran says, hi, I had Y90 on January 24th, and why am I in lots of stomach pain ever since? Or is that common after that procedure?
Well, it could be, even though it's a little bit outside of scope of my practice. That's usually interventional radiology scope. However, it's very common procedure, very commonly done. There is such a thing as post-embolization syndrome. It is usually happening more frequently, not necessarily after Y90, but after blunt embolization, which is considered to be a little bit more invasive. But it's possible to have discomfort, because depending on the volume of the disease in the liver that was treated, people could have symptoms. If it's just little tumor that was treated, it's probably less likely. If there is a lot of disease and the treatment is not as selective as we wish to be, in most cases. So some people might have discomfort. However, it could be something else.
All right. Well, thanks for your question. And if you have a follow-up, Simon, let us know. From Gwendolyn, this will probably be a simple one. Will the Florida Cancer Center be working with Medicaid/Medicare patients? Any knowledge on that?
What entity? I'm sorry.
The new cancer center that you're helping.
Oh, Arizona Family Cancer Institute. And what insurances? Medicare, Medicaid?
Yeah, she said, will the Florida Cancer Center, the new one, be working with Medicaid/Medicare patients?
Yes, our cancer center is working with Medicare and Medicaid. Of course, as you know, it's always very complicated. There is a long list of different policies under every insurer, and some of them are taken, some of them are not. But as far as I know now, so far I was not told no.
Okay, got it. Hopefully that helps, Gwendolyn. And let us know if you have another question. From Marcellus, do neuroendocrine tumors cause heart attacks and/or heart failure?
Well, that's two different things. Heart failure. As you know, there is such thing in many cases as carcinoid heart. High levels of serotonin, presumably serotonin, maybe something else, but so far serotonin is the one to blame, could cause damage to the valves in the heart. And valves, when valves are not working correctly, leakage starts, and eventually people could develop heart failure. From that standpoint, yes, it's possible, it's known entity. That's why it is critically important when people have carcinoid syndrome. When people don't have syndrome, it's no symptoms, but serotonin is high. It happens sometimes. People have asymptomatic high serotonin levels. It's critically important to have ultrasound of the heart, so-called 2D echo, to look at the status of the valves. It's critically important. So this is the heart failure. Whether it could give you heart attack, that's probably more rare condition. It's not something that we are commonly talking about. I think valve damage is much more common.
Got it. And so, Marcellus, this is an opportunity. I mentioned at the top of the program how many videos that I've helped CCF with over the years. And I like to say and remind people every week too, almost any topic you can think about, there's a video for that here on our database, either here on Facebook or on YouTube. And even specifically for this show, even though it's kind of a Q&A and anyone can ask any questions, last week specifically, we had on Dr. Heidi Connolly, and mostly talked about carcinoid heart disease and echocardiograms and things like that, specifically what you're asking about. So you don't even have to look that far back, just last week. So you go to our videos tab, and Luncheon with the Experts with Dr. Heidi Connolly can hopefully help answer some of those specific questions about that specific topic. So, and that applies to anything, everybody. We got a lot of videos out there: surgery, PRRT, lung nets, you name it. I think we've done a video about it. So lean on those resources. That's legitimately what we are here to do. Okay, next question from Fernando, our friend Fernando. Doctor, I'm not sure if this is part of octreotide side effects, but my smell has ramped up to where sometimes it's way strong for a minute and then it levels out. Does this have anything to do with it? Have you ever heard of something like that?
No, I haven't heard anything like that. Again, could it be related? Yes. Could it be not related? Yes.
Yeah.
Does it mean anything? Probably not, especially if it's in a wave form and it goes back to normal. Well, some people could have odd reactions. If you remember that there was quite a few years ago, there was a period of time when patients, I believe they were on one of those somatostatin analogs out of the two, that they started having headache more frequently than before. It was a little bit unusual. And it took an astute patient to look and dig deeper, and they figured out that one of the chemicals in the vehicle of this drug, not the active component, but one of those chemicals that keep everything balanced and stable, was changed by the manufacturer. And thinking was that the headache was related to that. So that's why odd things could happen. The fact that they are odd or rare or unusual, it does not mean they're not valid. They are valid. Think about the recent story of the COVID. Remember when it was just starting 2.5 years ago, and people, I believe in Europe, started reporting, young people started reporting issues with smell. Nobody was taking them seriously. Look where we are now. This is one of the main symptoms of COVID syndrome. So that's why the fact that it's rare, it does not mean it's not there, and it does not mean that it's not valid.
Great point. And I saw someone else chime in the comments. You can't see this, Dr. Naraev, but Sarah says, my smell has also been more intense. So this is a good example of sometimes we don't always have the data, but anecdotally, someone else might have experienced that. So always good to share information, folks. Moving forward from Mary Helen. What can I do to relieve the extreme carcinoid syndrome that I have or that I'm experiencing? And Dr. Naraev, let's also use this moment to, for those who may not be familiar with that term, explain briefly what carcinoid syndrome is, and then let's talk for Mary Helen a little bit about anything that could be done for relief of those symptoms.
Carcinoid syndrome, it's a complex of symptoms or signs that patients could experience when they have neuroendocrine tumor that is producing certain chemicals. We tend to blame, again, serotonin for many things, but as you know, neuroendocrine cancers can produce many others, long list of chemicals, and they affect the body. So when people could have different symptoms, It's not necessarily one size fits all. The more common, diarrhea and flushing. So many people could have issues with the heart, as we discussed before, carcinoid heart. Retroperitoneal fibrosis, when people develop scar tissue in the back of the abdomen, where the ureters are, the tiny pipes that connect kidneys with the bladder, and that's the way urine gets out of the kidneys into the bladder. It could be affected as well. So some people have all of the above. Some people have something. It's possible to have diarrhea and not have flushing. It's possible to have flushing, not diarrhea. Some people do have wheezing in the lungs, especially when they have episodes of flushing. Some people don't. But some sort of combination of those symptoms, any combination of those symptoms constitutes carcinoid syndrome. In terms of how you treat it, it depends. It depends what kind of tumor, what kind of chemical, how bad it is, and where the disease is located. Very frequently, the mainstay treatment, somatostatin analogs, injections of samprostatin or lanreotide, can control the symptoms. And that's how initially samprostatin was invented, to control the symptoms. And only later we realized that it actually controls the cancer growth. So could be that patients with diarrhea related to carcinoid syndrome that is not controlled with those injections could be given medication. It's a pill called telotrestat. That's the only one developed to decrease serotonin levels, and it helps with diarrhea in many cases. Anecdotally, we know from the patients that it helps them frequently with flushes as well, even though it's not approved for this indication by FDA. So if the tumor that is producing chemicals is large, and let's say it's located in the liver, treating the tumor directly, for example, with liver-directed treatment, the Y90 that we discussed before, or chemoembolization or blunt embolization can help. It kills the tumor, or at least decreases the burden of the disease, and it produces less chemicals. Sometimes surgical removal of those chemical-producing tumors might help to decrease the symptoms. So, and as well, just good old symptomatic control. For example, many people do not completely appreciate how powerful properly used Imodium could be, over-the-counter Imodium. I'm still surprised that many people don't read the box. Many people take it 2-3 times per day and it's not working. While classically you're supposed to take an extra pill after each subsequent bowel movement. And when taken like that, it helps a lot. It helps a lot. And as well, back to diarrhea, as you know, there is I call it cookbook for neuroendocrine cancer patients. It's a book published by Lexicon, the manufacturer of Tercera, that teaches people about 4 different subtypes of diarrhea and how different subtypes could be helped with dietary means. It could help as well.
It's a great point. Yeah, thank you for that. And thanks for your question. Next question from Shane. Is the stomach fundus a likely spot for metastases from the pancreas, or is it likely a second primary?
That's a good question.
And he puts in parentheses, he puts in parentheses MEN1 negative, just for some clarity.
Okay. Pancreatic neuroendocrine tumor metastasizing into the stomach, it would be a little bit unusual, especially if this is, I understand, inside of the stomach, not outside of the stomach. Outside, you could potentially speculate there might be some superficial spread, etc. But as you know, this is cancer. Everything is possible, but some things are more likely, some things are less likely. So far, it sounds to be less likely that neuroendocrine tumor of the pancreas went into the stomach. But it will all depend how exactly the tumor in the stomach looks. Is it superficial? Is it going deep into the tissue? But again, it would be a little bit unusual to go from the pancreas into the stomach.
Got it. Thanks, Shane, for your question. Hopefully that helps. And again, let us know if you have any follow-ups. From Jade, with regards to carcinoid flushing, can you talk about what types of flushing, if wetness could happen, if rare, and correlations with types of cancer, specifically stomach cancer, please?
Okay. So flushing, it's always a touchy topic because people could have flushing for so many reasons. And
right.
Late Dr. Oderisio and I, along with Dr. Havdanovson, were planning to write a review of how to treat flushes in people with neuroendocrine tumors, but never got to it. I will probably have to readdress. So classic flushing related to carcinoid syndrome considered to be dry, which means people don't sweat. People don't sweat. But is it possible to have some flushing with sweats? Yes, it is possible. It is possible. Again, one size does not fit all. Is it possible that flushing is related to something else? It's possible. Could it be related to menopause? It's possible. When we talk to patients who already stopped having periods, we always ask how the change of life went. How was it? Was the flushing then different from flushing now? Because sometimes people never stop having flushes even after the period stopped. So it's complex. Again, flushing could be different. Sometimes people have the whole body flush. Sometimes it's only face. Sometimes it's just the face and the upper part of the chest. Just recently, I saw a patient already here in Jupiter that complaint is only face turns red and sweating happens only in the face, nowhere else. Wow. So it's a very, very non-specific symptom. It's very non-specific symptom. So, however, I probably told you last time the story that I had a patient that was the favorite grandfather of his grandkids because he could do the trick. On demand, he would have like very little amount of any alcohol, like 5-10 milliliters. Yeah. And within 5 minutes, he would be purple red and flushing, etc. And kids were laughing. Kids were laughing because it's funny. No other grandparent could do that, and he could. So, and I asked him, did you talk to your doctor? Don't you think it's not right? He said, yes, I did talk to my primary, and the doctor said, just don't drink alcohol. So, well, eventually the patient was found to have widespread metastatic disease. And as soon as we started him on injections of somatostatin analogs, grandkids did not enjoy him that much because he stopped flushing. So, but that was rather an extreme. He would completely turn purple. So flushing is different, but it's always important to sit down with your doctor and talk in detail.
Absolutely. I do remember you sharing that story, but I appreciate you sharing it again. That's wild. Thanks, Jay, for your question. Next question from Edgar. Okay, this is a good question, I think. Assume someone with a NET needs non-NET related surgery. So in that case, what precautions should the surgeon take, if any, and what precautions should the patient take? And then also, can we assume that they have sandostatin on hand because they are treating a NET patient?
Great question. So I think it's a question about so-called carcinoid crisis, because usually, and we just published big paper how the paradigm is shifting in our appreciation of carcinoid crisis and our approach. So carcinoid crisis, what happens when people have neuroendocrine tumor that is functioning? And in most of the cases, people have carcinoid syndrome in some shape or form, diarrhea, flushing, etc. What happens when they have a surgery? The way we see it, two things could happen. Either surgeon manipulates the tumor, let's say that they try to debulk the tumor from the liver, remove it, and they squeeze it, and extra volume of chemicals gets into the bloodstream. Or some sort of interaction between high levels of chemicals already pre-existing in the bloodstream happens with medications used for general anesthesia. And what happens, people go into carcinoid crisis, which in common sense is blood pressure drops very low, and standard means of resuscitation or helping with that intraoperatively, which is usually give lots of IV fluids rapidly to restore the volume. It usually does not work. What works is instant use of octreotide or short-acting sandostatin. So, and we don't know truly how frequently it happens, depending what surgeon you are talking. So some people say, or I do the surgeries for 30 years, I never saw a case, and some people see those cases regularly. Problem is when we started looking into this carcinoid crisis situation for our paper that we just published in February, there is no standard definition of what carcinoid crisis is. So much more research is needed. But in common sense, the way it is right now, when people have carcinoid crisis, we think he probably is at increased risk of carcinoid crisis during the surgery. Usually massive surgeries require general anesthesia. So the most common misconception that I see it sometimes is that, oh, you are already on monthly injection of sandostatin or lanreotide, you are okay. No, you are not okay. Those injections are not given to control carcinoid crisis. Those injections are given to control tumor growth and control the symptoms. So that's why one of the protocols that is being used in Phoenix and in our program that we built there and some other institutions is before the surgery, before people go under, usually it's in the waiting room, so-called pre-op room, a bolus of short-acting octreotide is given, IV as an infusion. So, and then patients are started on the drip, because if carcinoid crisis happens while you're doing the surgery, this is not the time to call your pharmacy and ask, do you guys have short-acting octreotide? It's too late. It will take some time. You might not have this time. That's why the usual approach is to start the drip at a certain number of milligrams per hour. And if, God forbid, something happens, it's already in the system. You can always increase the speed, increase the rate, and give more octreotide. So, and after the surgery, in the post-op room, in the observation, sometimes extra bolus is given, sometimes bolus is not given, and the drip is stopped. So that usually helps prevent the crisis. And if crisis, God forbid, happens, at least you're fully prepared, because the best action when the crisis is happening is actually to use short-acting octreotide. Hope I answered your question. Because if a patient has non-functioning tumor, so then probably risk of carcinoid crisis is not there, and no special precautions are needed.
Got it. Thank you. And thank you for your question, Edgar. Hopefully that did help. Folks, if you just are joining us or you joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And we are here today with Dr. Boris Naraev from Jupiter Medical Center. And a lot of great questions today. If you guys are getting some value from today's conversation, I know that I am. You've been asking good questions. If you're getting some value and you're enjoying today's session, write Jupiter in the comments section and let us know. We always like to see your feedback because we want to keep bringing you good content and good information. Let's keep the show going. We have about 30 minutes left, so plenty of time to get your questions in to Dr. Naraev. From Karen, our friend, I recently read, Dr. Naraev, that coffee reduces serotonin. Is this true? Have you ever heard of that?
Well, looks like coffee is becoming the most studied substance in the world. And there are so many publications about coffee, and you can get lost. Coffee is good, coffee is bad. Coffee prolongs your life, coffee shortens your life.
Right.
Coffee gives you cancer, coffee does not give you cancer. Truth is, I don't know. I don't think it would impact the levels on industrial level to somehow play a role in neuroendocrine cancers, but it's possible. Coffee is a stimulant. Coffee is a stimulant. Could it stimulate serotonin production? Possibly. Could it stimulate serotonin production? If you remember, Dr. Oderisio, God bless his heart, he was always telling that there are two pools of serotonin. One is in the brain and one is outside of the brain. Mm-hmm. And the one that is outside of the brain is huge compared to the in brain level of serotonin. So which one might be affected by coffee, we do not know. But to put things in perspective, many of you who ever had to collect urine for 24 hours, people usually don't forget this thing, not the collection part, that the time when you need to deliver it to the lab, the gallon. So, you know, this is being done in our world to check levels of 5-HIA, which is product of biodegradation of serotonin, which is indirect way to tell if serotonin is elevated. And as you know, when the test is done or ordered properly, patients are told to avoid certain foods for 72 hours, like avocados, bananas, nuts, etc. Coffee is not on the list.
All right, good to know. Thanks for your question, Karen, and good to see you. From Shane, does SUV on a gallium scan correlate with the efficacy of lanreotide?
That's a good question. SUV on dotted as is little bit different than SUV on FDG PET scans, which is the oldest PET scan existing as far as I recall. So I don't think there is hard data. I don't think anyone looked into that. Now that there is research trying to figure out if there is some sort of correlation between the level of expression on PET scans, dotted PET scans, and efficacy of PRRT. So, but in terms of use of lanreotide or Sandostatin, well, if you were to think about it theoretically, what the dot-to-date PET scan is using, it's using the fact that majority of neuroendocrine tumors have somatostatin receptor type 2 on the surface. And this is the part to which dot-to-date component of the PET scan has affinity. It goes there and attaches. And you can see it on the scan because little gallium or little copper isotope is attached and it's bright. So if you were to speculate, the brighter the tumor, the more receptors. The more receptors, it's the same receptors that are being used by lanreotide and sandostatin to attach. It's still the same concept of using this receptor for everything, for diagnosis, for treatment, and for PRRT as part of the treatment. So theoretically, one would speculate that the brighter it is, the more receptors are there, and probably sandostatin or lanreotide will be effective. And as you know, to twist the situation a little bit, when you are deciding whether the patient is a good candidate for treatment with PRRT, which is one of the latest and greatest, as you know, Lutathera so far is the one that is approved, you must prove that the tumor expresses somatostatin receptor type 2 on the surface. And there are two ways to prove. The easiest would be to do dot-to-date PET scan. If tumors are bright, that's the receptor right there. Means Lutathera, the drug, will have something to attach to. So on the other way to prove it is to actually do the staining on the tissue. It's a little bit more cumbersome. So that's why from practical standpoint, if we see that there is uptake on dot-to-date PET scan, it is likely that the somatostatin analogs will be effective.
Got it. Thank you. From Linda, are there any long-term considerations for being on sandostatin? Can it cause any health issues with prolonged use, or the benefits outweigh any potential concerns?
Great question, because now those medications been around for quite some time, and I do see patients who've been on injections for many years. So like any medication, even though it's somatostatin analog, again, analog of something that body makes, the levels are much higher. So theoretically speaking, it is possible. What we see in real life in the long run, what happens probably more frequently is issues with blood sugar control. It's not necessarily that somatostatin analogs make you prone to developing diabetes. It turns off in certain way the function of the pancreas, and pancreas is not producing as much insulin. So issues with blood sugar control could be happening, but could it be dealt with? Yes, absolutely. And does the benefit outweigh the risk? Probably, because if it controls cancer, this is the main thing. We can deal with everything else. So other thing that could be bothering people with long-term use, diarrhea. Because again, universal switch off, pancreas is not as productive because it's being controlled by the injections. Not enough enzymes are made, and as you know, many patients are taking medication for that, creon or some other enzyme substitutes, pancreatic enzyme substitutes. That diarrhea could be bothering. This is on big scheme of things. What I observed locally, at least in a couple of patients, when people were getting those injections in the buttocks for many years, it's 10 plus. So what was happening, lots of scar tissue was formed, because you can imagine it's trauma every time. It's trauma because needle goes in, and a trauma because you have to inject the substance. And people developed a lot of scar tissue. And what was happening and still is happening, when you remove the needle, the soft tissues, they don't collapse properly. And sometimes the drug is seeping out, even though it's thick, as many of you know, consistency is thicker than water, but it still happens. This is the local result of long-term use.
Got it. Thank you. And yeah, great question, Linda. Lots of people saying Jupiter from earlier, chiming in and following directions. So great job, everybody. From Fernando, who we've heard from a couple times today, there are some new treatments still in testing, but in the final stages to add to PRRT. Would you know when and how they're going to work? Like triapine and Metastasizing, I think that's how you spell them. Yeah. So you know what he's referring to?
Yes. There are so many compounds and approaches that are being studied now in different stages and in different places in the pipeline. It's amazing. I just looked yesterday at the list of clinical trials currently available with different. It's amazing. But the usual way for any new treatment, as you know, it has to go through the clinical trial. That's what PRRT has to do. It had to go through the clinical trial. Now, all the additions we need to prove. We need to prove that anything that we add to PRRT will be at least as good as the standard of care, or hopefully better. So the standard way would be to proceed with clinical trials, and that's where the time consumption happens, because it takes time. It takes time. So I know that there are clinical trials ongoing with different PRRT drugs, not necessarily mixing PRRT with something, but you know, there is a clinical trial. It's called COMPETE. There is another clinical trial that is coming up soon in the United States. It's called COMPOSE for higher grade neuroendocrine tumors. This is utilization of PRRTs. And you're right, there are so many components are being studied in conjunction with PRRT. So I'm looking forward to having it in real life, but so far nothing has been approved yet. As you know, the latest addition in the neuroendocrine world was the fact that last year, belzutifan was approved by FDA to use in people who have von Hippel-Lindau syndrome. This is an inherited condition, and they have pancreatic neuroendocrine tumors. That's the latest and greatest. It has nothing to do with PRRT, but it was approved. So, but we're looking forward. We're all very anxious to see how PRRT will work. And as you know, there are many discussions and many theories how PRRT could be used. Because I know that in some countries, Lutathera-like compounds are being used for liver-directed treatment, so direct infusion into the liver, and it's being utilized, not in the United States. So now Excel Diagnostics in Houston, they're looking into alpha-emitting compounds, alpha-emitting isotopes like lead and others to see. You know that in Germany, they routinely use PRRT with Y90 because Y90 radiation travels a little bit further compared to lutetium. And the theory is if you have a big tumor, it makes sense to use Y90 because it has probably a better chance of affecting it. And sometimes they do in Europe, they do one time lutetium, one time Y90. So it's very interesting to watch where the field is just in the last 5 years. It's amazing development. So we're looking forward to it. But again, it's a matter of not just efficacy, it's a matter of safety. We have to be safe. There is no such thing like a drug that has no side effects. Everything has side effects, including PRRT. That's why no matter how exciting something sounds, it must go through clinical trial for two purposes. Make sure it's safe and make sure that it's working.
Got it. Thank you. So next question from Ajid. Ajid says, going back to flushing, I found that being a Black person, the descriptions of flushing that are described in the books, i.e. red face or skin, don't necessarily apply to me. So do you have experience with flushing for people of color?
Yes. And it's usually what people do. It's difficult to see, as we say, it's difficult to see. You are correct. So that's why it's very important to sit down with your doctor and talk, because we usually dig deep. We talk about everything. If you have flushing around your, if the person is a lady, if menopause cause flushing, that's the same flushing. Some people, as you know, have flushing during the perimenopausal period. Sometimes people have every month. And we talk about sensation. People in majority of cases can feel it. Rarely it's other people see and you don't feel. Usually you feel. So yes, when you cannot see it because of the skin color, so you drill down and you talk if people feel anything, because usually people know themselves. When something is not right, they can describe it quite well. It's usually feeling of warmth, or some people feel that little insects are running on the skin, or some people just feel hot all over, or sometimes people can feel hot only in the face or only in the chest. So yes, it is different, it is challenging, but it can be dealt with.
Got it. Ajid, hopefully that helps. I know you've had this question before. So hopefully that helps give you some clarification on that. And I just appreciate you always being here. So I remember when you joined us not too long ago. So moving forward, folks, we got about 15 minutes left, and we're going to try to get to as many of your questions as we can. Great numbers today. So from Paula. Paula says, sometimes when I have a rapid onset flushing, my body trembles and jerks. My octreotide injections help it stop. And I have discussed with my oncologist. She just doesn't give any more information about what was discussed and what was said. But any ideas from you, Dr. Naraev, of what that may be coming from, or what to do?
Well, if it coincides in time with flushing, it's only logical to suspect that this is probably related. This is probably related, because if we think that flushing is related to the fact that serotonin levels are not constantly and consistently high, but rather go in the wave-like form, so probably, I'm just speculating here, but here is the theory, when the level is high, you have the symptoms. That's why many people have altogether, they have rapid onset of flushing, wheezing starts, and they have to run to the restroom because the bowel movement is coming. We can speculate that if levels are very high, it could potentially affect the muscles as well. Could potentially affect the muscles as well. That's a theory, but if it coincides in time, it would only make sense. The most important thing is that something is there that helps. If octreotide injections help, so this is great. I would guess that we are talking about short-acting injections, because long-acting wouldn't help that fast. But right. Many people find that if they know the episode is coming and they inject the short-acting octreotide, it helps.
Got it. Thank you, Paula. Appreciate your question. Next question from John. Another great show where my wife has this disease, and it is so helpful. So many great questions and many things mentioned we have seen her experience. And I just wanted to add that because I appreciate that, John, and I appreciate you being here every week for your wife, I believe is Lorraine. So the question is, Dr. Naraev, is there a way to lower serotonin levels, or is it just part of the journey?
Well, these are two questions. Is high serotonin level part of the journey? For many people, yes. For many people, yes. So the second question should be reduce the level of what could be done. This is a great question. We are moving now from our previous understanding of the role of serotonin, because we thought, well, yes, some tumors produce serotonin. Serotonin gives you carcinoid syndrome, classic flushing, diarrhea, sometimes wheezing, and some other things, including carcinoid heart disease and retroperitoneal fibrosis. But there is a drug to reduce serotonin level. There is a drug, as you know, telotristat. This is the only one that is approved, and it works. But it was only approved to treat carcinoid syndrome diarrhea, not completely controlled with injections of somatostatin analog. It wasn't approved for flushing, even though in clinical trials they got very close to statistically significant numbers, but they were not statistically significant, so it wasn't approved for flushing. We do see in real life that it helps with flushing in many patients. Mm-hmm. So, but what I was getting at now, there is a question is, many people have high serotonin, but no symptoms. It happens. This is real thing. Question is, should we decrease the level or not? And this is a matter of debates and matter of designing clinical trials, because one of the theories is, what if, let's say, theoretically, we put a person on telotristat and the person has high serotonin, presumably. Will it decrease the chance to develop carcinoid heart disease? That would be huge, but it will take some time to answer. So other thing that became the center of attention lately is some information, and it just latest NANETS meeting in October, North American Neuroendocrine Tumor Society, researchers from the University of Iowa presented data that inhibition of serotonin production suppresses growth of neuroendocrine tumors. It was not in patients, it was done in the lab, but this is the first step. Because now the question is, if high serotonin levels somehow promote tumor growth. Mm-hmm. If it will be proven that this is the case, then the next question will be, does it make sense to control serotonin? Will it control the tumor progression? Those are great unanswered questions, but there is so much research in that direction that we will probably have some answers soon. So is it part of the journey? Yes. Should it be controlled? If it causes symptoms, definitely. So if it does not cause symptoms, that's questionable. We do not know. We do not know. But frequently what we see that just doing the first step, starting as a somatostatin analog in the settings of metastatic disease, it controls the disease and it controls the serotonin levels. When you check serial serotonin numbers or 5-HA numbers in urine, you see that it is working.
Got it. Thank you. About 10 minutes left, folks. We're moving forward. Again, from Ajid, I have Sandostatin 30 milligrams LAR every 2 weeks. On the right side, the injection site hurts for 4 to 5 days to a point that I have to take painkillers. So that's significant. On the left side, I barely feel anything. Is there any advice that you might have to ease the pain?
It is a bit unusual.
Right.
Well, so many scenarios go through my head. First, you probably know by now that this is operator dependent. So, and some people are happy with one operator and they just try to stick with this operator because, you know, it's a deep injection. It's a deep injection, and probably the more expertise the injection nurse has, the better the outcomes are. So in many cases, as many of you know, people try to put ice before the injection goes in, so to numb it up, the actual moment of insertion. Sometimes people use those numbing sprays before the needle goes in. So but in your case, looks like putting ice would not help because pain there for 4 or 5 days. So maybe it would make sense to consider, if it's painful, not to inject on the right side if it hurts on the right side. However, it will put increased burden on the left side. So, and other thing I would probably consider doing is actually looking at the area in question, at the areas of the injections with some sort of imaging to see maybe there is something that makes this area more sensitive. So maybe there is some micro abscess was somewhere like in area of inflammation, and then it resolved and there is scar tissue formed or something of that nature. And if you keep injecting into the scar tissue, obviously it's rigid. And when you add the medication, I'm just speculating, but I would look with imaging at that area, either CAT scan or MRI, or maybe just start with ultrasound to make sure that there is nothing obvious.
Got it. Next
and
question.
If I may, Ray,
yeah, please.
Since we're talking about those injections, other thing, which is an exciting development, you know, we are getting closer and closer to having somatostatin as somatostatin analog in the pill form. Not necessarily the pill, maybe capsule, but in the oral form. That would be great. You know that it was already approved by FDA to treat people with acromegaly, which is a reasonably rare condition. And I know that there is research towards using it to help people with neuroendocrine tumors. And hopefully we will be there soon, and then all these questions and all these situations will be relevant. Hopefully we'll be just take a pill and that's it.
Got it. Thank you. From next question from Debbie, and other people have this question as well. What is available for patients who have no receptors?
That's a difficult question. That's a difficult situation.
Mm-hmm.
So let's talk about what would be excluded, what's not available, because everything else will be available. Okay. If there are no receptors, PRRT probably will not be effective because it will have nothing to attach to. So somatostatin analogs, it's a little bit controversial. I believe NCCN still says that it would make sense to try, even though there is no uptake on dot-to-date PET scan. I need to look at this particular statement after this meeting. But theoretically speaking, if there are no receptors, so somatostatin analogs might not work, or at least work as well, because they have nothing to attach to. So, and this is about it. This is about it. So what is based on the receptors? Somatostatin analogs in terms of treatment, and PRRT. So in terms of imaging, dot-to-date based PET scans. So, and then everything else is available. And then we need to look into, is it well-differentiated tumor, or is it poorly differentiated tumor? Less aggressive, more aggressive. And then you break down your treatment options. It depends where the tumor started. Is it pancreatic? Is it lung? Is it rectum, stomach, small bowel, etc.? It depends where the cancer is now. If it's only in the liver-directed treatments do not depend on the presence of the receptor. Unless we're talking about infusion of Lutathera, but this is not standard of care in this country. So not that many treatments will be excluded. Question is, of course, it's unfortunate situation because, as you know, somatostatin analogs are effective. PRRT is effective. But if we have what we have, we just need to deal with that. But it's not completely hopeless situation. There is always something. As we stated in the beginning, we have many treatment options. And not having a receptor, it's just a detail of the situation, but there are still treatment options, and people usually could be treated.
Got it. Thank you. 5 minutes left. Still moving forward. From Suze, I was diagnosed with a NET on my pancreas head last year. I had the Whipple surgery or Whipple procedure in July. My doctor wants to just do MRI abdomen for follow-up, but I'm allergic to dyes. So I was wondering if I should have a gallium dotatate 68 to see if I have a NET. I was hoping I was cancer-free.
Great question. So actually, there's two questions in one. Dotatate-based PET-CT is not recommended for follow-up.
Okay.
Simply because sensitivity of conventional imaging methods like CAT scan and MRI is higher than sensitivity of dotatate. Just to put it simple, CAT scan or MRI could pick up smaller things than dotatate PET scan would pick up. For tumors to be bright, they have to be reasonably big, not super big, but still bigger than they would have to be picked up by CAT scan or MRI. So that's why it's not recommended for follow-up. We see it a lot in the community. That's not what should be done, either CAT scan or MRI. So if you are allergic to dyes, truly dyes, maybe we are talking about iodine-based contrast. This is usually for CAT scan. For MRI, they use gadolinium, which is different. It's not iodine-based, and it's not technically a dye. Some people can be allergic to gadolinium. So in this case, unless this is an unfortunate situation that the person is allergic to two, that's difficult. So, but if you're allergic to one, you can do another. You can either have an MRI of the abdomen and pelvis with either Gadavist or Eovist, two different types of IV substances that are given to enhance the picture. Or if the person is allergic to those compounds, you can use CAT scan with IV contrast. Without IV contrast, it's probably not a good idea. You want the enhanced picture. So, but you can always choose, because per guidelines, it's either CAT scan or MRI. So either or, they're probably equally good.
Got it. Thank you. Let's try to get a couple more if we can. From Gwendolyn, when an oral chemo is added, what goes into the decision between Captem and Afinitor? I'm new to this, and it seems like those are the two most common choices.
Okay, so Afinitor is not a chemotherapy. Okay,
thank you.
Chemotherapy, it essentially use of poisons that kill the cells. Okay, so-called cytotoxics. So Afinitor is not a cytotoxic. It's considered to be biological treatment. It's milder in terms of side effects. It's not chemotherapy. So there are two different things. In terms of what goes into decision making, first and foremost, extent of the disease, how rapidly the disease is growing, how bulky it is, and what the Ki-67 is. If Ki-67 is higher, let's say 18, 20, going into this direction, not 1, 2, 3, because the higher Ki-67, the more efficacious chemotherapy will be. As well, if there is large disease burden, and just because how big it is, it threatens organs next to it, and you really need to shrink, you use chemotherapy. Chemotherapy shrinks the fastest, including Captem, one of the greatest regimens. So Afinitor would not shrink as fast. However, if you're looking at disease progression, but it's not bulky, you don't need to shrink it, it just grow a little bit, but not still. The disease is not large. And Ki-67 is lower, probably you will be thinking more about Afinitor than Captem. So, but overall, it is a complex decision-making as you can imagine, but several things must be taken into consideration. Ki-67, extent of the disease, how bulky it is, and if anything is being threatened, then you need to shrink.
Got it. Well, folks, that is our hour for today. A bunch of questions, or not a bunch, but a handful came in there right at the end. So I just want to make sure that I reiterate one more time if we didn't get to your question. One, tune in next week. That's why we're here every week, because we always get these questions and we can't get to them all. But also, you can reach out to Carcinoid Cancer Foundation here on the Facebook page. You can send them a direct message or at carcinoid.org. Dr. Naraev, thank you so much. Great answers today. Great information. We appreciate you being back with us.
Thank you very much for having me.
Absolutely. And there was a line that you said at the very beginning of the program, which has resonated with me. Once you're in, you're in. And you meant, I think, the NET community. And I feel very much the same way. I have been with the NET community for 10 years now, going on 11. So I feel like I am in that as well. Thank you to everyone else for joining. As always, we hoped that this program helped answer some of your questions. And again, reach out to CCF if you have any follow-up questions or need some information. Thanks as always to our presenting sponsor, Ipsen Biopharmaceuticals. Without them, we couldn't do the program. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.